We go. Okay. Welcome, everybody. This is Viviette White from the Charlotte Mecklenburg Library, and I would like to welcome you today to another part in our health series. And today we have Atrium Health's Sarah Head with us to talk about ovarian and breast cancer. Two major factors in a lot of our lives, whether we know of someone with either ovarian or breast cancer, or we might have been on that tilt where we might have had a diagnosis for it. It's scary that at certain ages, you know, they tell you you have to be tested for this and that, but it's an ongoing test. I think people should always get checked, especially if you're not sure if it's a part of your family, or you could be the first in your family to have it. So that's the thing. We're going to talk about a lot of different things, but it's good that we're having this conversation. Sarah, thank you for being here.
Of course. Thanks for having us, Viv. I appreciate it.
Mm-hmm. Well, you can go ahead and get us started off.
All right. So my name is Sarah, just like Viv said, and I work with Atrium Health Levine Cancer Institute. I work on the Disparities and Outreach team, and what that means is we provide education, just like today, about cancer screening, signs, symptoms. We help connect patients throughout LCI's footprint to resources, primary care, cancer screenings. And so we work on the pre-side of things. So we are with the community, again, education, screening events. And kind of what we like to joke about is we are trying to put LCI out of a job, right? So we are trying to prevent or catch cancer at its earliest stage. And so that is what we do. So happy to be here. I'm going to share my screen, get the PowerPoint pulled up. So we provide cancer screenings for any of the major primary screenings that are available. So skin screening, prostate screening, breast cancer screening. We can connect you to resources for your pap smear. So if at any point, you or a family member is in need of a cancer screening or has questions about which one should get or which one's needed, please don't hesitate to reach out. If you have community organizations or groups that you would like us to come to do education or bring any type of screening there to you, we are happy to work with you on that as well.
I made you co-host, so I believe you can start sharing your screen at this time.
Oh, we sure can.
Yay! Okay. Perfect.
Thank you.
Awesome.
Okay. All right, so we're going to rock and roll here. So let's talk about female reproductive cancers and the steps to take for prevention and early detection. So just to kind of start us from the very beginning, cancer starts when cells begin to grow out of control. So you can see here the image on the left. That's just an animated image of what our blood cells could look like. And then the image on the right is just showing when cells start to grow out of control, they're going to divide and multiply and not take the same shape. And that is how cancer starts. So it can start in any part of the body and spread to other parts of the body. So where GYN cancers commonly start could be your ovaries, which are where your eggs are made and stored. Could be the fallopian tube, which is the egg's path to the uterus. Could also be, so there's also uterine cancer. So that's what holds the baby during pregnancy or your womb. And then there's also cervical cancer, which is the opening of the uterus. So those are those GYN cancers that we're going to be talking about today. Specifically, ovarian cancer. Again, that's the cancer that begins in the ovaries or at the very end of the fallopian tubes. It affects about 1 in 78 women. It mostly occurs in older women. And what is very important to note here is that an ovarian cyst is not cancer. So those are just things as women that we have. I don't know if you've ever had one. I have before. Some of them resolve on their own. Some of them have to be removed surgically, depending on the size of them. But It's a natural thing that comes with our cycles, and again, is not cancer. So risk factor, you're going to see some repeats of the risk factors for a lot of our GYN cancers. But getting older, this is the same with breast that we'll kind of just briefly review at the end, but getting older is one of the biggest risk factors for a lot of cancers, which is really unfortunate because there is nothing we can do about aging, right? We're all going to age. And so what is important is knowing the signs and symptoms to look for, and then getting the recommended screenings. So being overweight or obese, so those are things we do have some control over. Having children later or never having a full-term pregnancy, there is some kind of hormone-related factors that could put you at increased risk for ovarian cancer. Using fertility treatments, kind of depending on hormones, that could put you at increased risk. Taking hormone therapy after menopause. So this is not as mainstream as it used to be, but hormone therapy after menopause has been linked to an increased risk of both breast cancer and ovarian cancer. So having a family history of ovarian, breast, or colorectal. So that's kind of weird because your ovarian risk factor increases not only if you've had ovarian cancer, but also breast cancer or colorectal cancer. The other thing, though, is that you do not have to have a family history in order to be at risk. So making sure that you're aware of that just because you don't know anyone who's had it, that does not guarantee that you will not have it. Having a personal history of breast cancer, again, that has to do with the hormones, puts you at a higher risk for ovarian cancer. And then smoking and alcohol use is going to put you at a higher risk for, again, most cancers. And so that would include ovarian. One of the big things that we like to educate patients about is just the option of genetic counseling. And so there is, that's one of the offerings that Levine Cancer Institute has for free. So you can have a genetic counseling consult free of charge. You do not have to be a patient, but that is just to talk through your personal and family history of cancer. So genetic counseling can help you know your risk and make informed decisions about your health. So if that's something you're interested in, again, that is a free service that LCI or Levine Cancer Institute provides to the community. And you can talk with your counselor about whether or not you would like to pursue genetic testing, which would then be the next step. So genetic counseling would be step one, and then genetic testing would be step two if you chose to get that information. And so considering genetic counseling, if you have a personal or family history of ovarian cancer, have a Ashkenazi Jewish ancestry, have 3 or more relatives, again, that's what we're talking about, 3 or more relatives in your family with prostate, breast, or pancreatic cancer. And then if your genetic testing was done at least 5 years ago. And that's just because there's been new updates and new technology to help us have more accurate testing. So ovarian cancer early detection. So get regular women's health exams. So along with our breast cancer recommendations, we highly recommend a yearly physical. That would include pelvic exam. That would include the clinical breast exam, and then just a check-in and a touch base of like, things are the same, or here are some things we're noticing different about my body with your doctor. And again, that's every year. You are your self's biggest advocate. So you're going to know your body and if things are off. And so we just recommend that yearly time with your provider. In addition to that, see a doctor if you have any bloating. And this would be kind of not one day of bloat. We all can get bloated from time to time, but if it is a reoccurring symptom, pelvic or abdominal pain, trouble eating or feeling full really quickly, and urinary symptoms such as urgency or frequency. I actually went to the doctor, this was probably a couple of years ago, because of the urinary symptoms. And so they did a couple of tests on my bladder, a couple of different ultrasounds, just to rule out something like this. So everything came back clear, but that is one of the courses of action as they're looking for causes for things like urinary symptoms. So the thing with ovarian cancer is there's not, that's also one of the reasons why we recommend genetic testing, is because there's no recommended screening test. We do not have a good screening for ovarian cancer. If you're at high risk, you can do a transvaginal ultrasound and a blood test that your doctor would order for you. And again, those are for high risk, and that high risk category is going to be a combination, most likely, or a very strong family history of ovarian or other types of cancer. So the next one we're going to talk about is uterine or endometrial cancer. And so that is when cancer begins in the lining of the uterus. It is the most common GYN cancer. It mostly occurs after menopause, and it's more common in white women, but African American women are more likely to die. And that's part of where our team comes in, like, not to have a lofty goal, but like we would like to see that change, where again, we're educating, and so that patients are aware of the signs and symptoms, 2, that they have access to care, and 3, that we can find those cancers earlier. And so what that means is that African American women probably sought treatment later or were diagnosed at a later stage. So again, similar risk factors for a lot of them. So the getting older, we can't do anything about that. We can, work on our weight, our exercise, our nutrition. So the risk factors would be lack of diet and exercise, meaning if you have a poor diet that is not filled with fruits, vegetables, whole foods, and lack of exercise. So those are risk factors. Again, hormonal factors play a big role in uterine cancer as well. Family history and any personal history of cancer is going to put you at risk for those types of cases, at higher risk. So again, this is another one that does not have a recommended routine screening test. And that's, again, where that yearly doctor's appointment is really important. And then just you being aware of how your body functions is really important. The signs and symptoms can include unusual vaginal bleeding, spotting or discharge, pelvic pain, a mass, or unexplained weight loss. And again, genetic testing is recommended if several family members have had colon or endometrial cancer. So another plug to be aware of your family history for other types of cancer. So cervical cancer, that is when cancer begins in the cervix, which is at the opening of the uterus. It is the most common cancer death in women, although survival is increased with the use of a pap smear. So mostly occurs between ages of 35 to 44. And Hispanic women are most likely to get cervical cancer, followed by African American women. So risk factors, one of the big risk factors for cervical cancer is the human papillomavirus, or HPV, maybe is what you might have heard of. Smoking, so again, diet and exercise, so not eating fruits, vegetables, whole foods, being overweight. Long-term use of oral contraceptives or birth control pills can put you at a higher risk. There is, studies are going back and forth about IUDs, but there could be an increased risk of cervical cancer with the use of IUDs. Having multiple full-term pregnancies, being younger than 17 at your first pregnancy, full-term pregnancy. Again, access to care, meaning the lack of a pap smear, and family history. So this one we do have screening for, which is great. So that is your pap smear. So ages 21 to 29, we recommend getting a pap test every 3 years. And if you are sexually active before 21, we recommend that they start at that time. Age 30 to 65, you're getting a pap test combined with an HPV test every 5 years. And then over 65, discontinued screening if no previous cancers are identified. And then the great thing about the cervical cancer screening is it's similar to a colonoscopy in the fact that it can also prevent cervical cancer by removing precancerous cells. So it's not only that it would find it, but it would also prevent it, which is huge. And so highly recommend, like it is, again, the best screening that we have. And there are options in Mecklenburg County and surrounding areas to get that service for free. And so we do not want lack of access or a doctor, being a barrier to getting the care that you need. And then personally, so these are kind of the national recommendations, but our cancer docs are on the more conservative line. And so, I get my pap test done at least every 1 or 2 years. And so as long as if you have insurance, as long as your insurance covers it, they are still covering it yearly and or biannually. So that's just something to know about. So cervical cancer prevention. So avoid unprotected sexual contact, do not smoke, and then get vaccinated. So I remember when the HPV vaccine came out, it was pretty controversial at that point in time. And I was very thankful personally to have a mom who was like signing me up for that. And so I remember getting my first dose, I think my senior year of high school, and then in college. That shows my age because that's when it was first coming out, but there's been a lot of testing since that time, and it has been proven to be safe and effective at preventing HPV. And then if you remember from a few slides before, HPV is one of the biggest risk factors for cervical cancer. HPV is not directly related. It is related to sexual contact, but regardless of if you are sexually active, we recommend the vaccine to prepare for that time if and when you choose to do so. So if your age is 11 or 12, the recommendation is 2 doses, ages 15 through 26, 3 doses. So prevention and early detection checklist. So what can you do to prevent or detect the early detection of both endometrial, cervical, and ovarian? So ask for genetic counseling if you have a family history. I think another step that needs to be added to the slide is to find out your family history, right? Make sure you are aware and informed of the family history of cancer. Get the HPV vaccination if you're in that age range, or protect your daughter, nieces, family, friends by encouraging them and educating them on the importance of doing so. Protect yourself during skin-to-skin contact. Get regular women's health exams. If you tune in to any of the other presentations, you will hear us say this time and time again of you are your biggest advocate. Call and schedule your doctor's appointments. Stop smoking or using tobacco, and get to and stay at a healthy weight. Those are the things that we have. There's a lot of things we don't have control over, and here are the action items that we do, that we have some say over and can really affect our long-term health. So with breast cancer, just to talk about that, the breast cancer, so the recommended screening for that is going to be starting at age 40. And we recommend yearly mammograms. So that is 1 mammogram every year. And that is up until a point where you feel like you would choose not to get cancer treatment if you were diagnosed. So if you are an 85-year-old who is still rocking and rolling out there, then like continue to get your mammogram. If you get to a point where you're like, you know what, I wouldn't go through the cancer treatment if I got diagnosed or the surgery, then that is kind of that personal decision of when screening should stop or can stop. The signs and symptoms are going to be very similar to ovarian cancer. In the fact that mammograms breast cancer is 1 in 8 women, and your biggest risk factor is being a woman and getting older. Being overweight or obese increases your risk of breast cancer. And then the personal history of cancer definitely has something to do with breast cancer as well. But a big point we like to drive home is family history is important, but with breast cancer and how prevalent it is, we cannot rest in the safety of like, I don't know anyone who's had it, and so therefore I am safe. So like breast cancer, more times than not, is what we call a rare or random occurrence as opposed to a family history. So family history is important with cancer for sure. Know your risk, be educated about that, but specifically with breast cancer, there's a lot of misinformation out there about, and women thinking that they don't need to get a mammogram because they don't have family who's had it. And so that is 100% not true. Your best chance at surviving breast cancer and having a less invasive treatment is getting your screening mammogram. So and getting that routinely, getting that regularly, that is going to be 100% the best option. The fact that your treatment will be less and that hopefully we're finding cancer at an early stage. Things that you can do for breast cancer in being an advocate for yourself is going to be your monthly breast self-checks. So we recommend doing those at the same time every month. So if you get your period, if you're on a regular cycle, we recommend doing it like maybe 2 weeks before that or 2 weeks after that, just so that you have a very good baseline again about your body and what it feels like. We recommend the clinical breast exam and then the annual mammogram starting at age 40. So that's kind of the 3-pronged effect to breast cancer prevention and early detection. And please let me know if you've got any questions. Happy to talk to you personally. If you want to call, happy to put you in contact with the resources at Levine Cancer Institute if that is helpful. And then we are available to do education or bring screenings to you or point you in the right direction if you have any company or community events that you would like us to be at.
There's a lot of information that I do have questions. I want to just pose a first question. I heard about more African American women having and dying from ovarian cancers. Is this due to lack of availability to medical treatment, or is it education about this? Mm-hmm. What have you seen in your profession? Like,
So Viv, that is a very nuanced question, mm-hmm. right? And it's one of those where I wish we said, "Oh, this is why," mm-hmm. And we could have a concrete answer. But I think it is there's so many factors in it. So I think there's the distrust of the medical system. That is definitely an issue of women of color not feeling comfortable or trusted by or like feeling like they can trust their medical providers to believe what they say is happening in their bodies. I think that's something that has to be said. 2, lack of resource or connection to care. That is definitely a big one too. So and as women in general, we're a lot more likely to be like, "Oh, it's fine, it's just this," right? And so it's a combination of not knowing where to go, maybe not having the funds to do so, and then not putting ourselves as a priority, right? And so that's why we believe education is important, and that's why we believe connecting people to care is important, because those are two of the biggest things that we can do, and that we believe that we can do to lower that cancer rate.
Yeah, and I think that it's a big disparity I notice in the African American community about access to the healthcare. Like a lot of areas don't provide those specific sources of ovarian testing and breast cancer screenings. And you mentioned quite a bit of like as early as you talked about the HPV vaccine for the young ones. I'm wondering how many people are open to that, because I know I personally, my daughter got hers when she had her screening right before she left high school. It's something as a parent, I guess it's a judgment call, but for me, I just felt it had nothing to do with, like you said, being sexually active. It was more like, if these cells are in my daughter's body, I want her to be protected. If anything should pop up, especially if you're learning about family histories of cancers, because I know there are cancers on both sides of my family. There are cancers within, our own bodies that have not even they haven't taken, I guess, clustered out, because we are vaccinated to prevent these cancers from developing within us. And that's why I think a lot of people need a shock to know that cancers are in you. It's just that they're not able to develop because as a child, you've had so many vaccinations. That's the whole purpose of being vaccinated.
With the HPV one, in particular, it is our 100% best prevention, best screening, not screening, best prevention. And it's not going to completely wipe out your risk, but it does HPV is also related to mouth cancers, throat cancers. HPV is related to a lot of different cancers, not only cervical. And so it really is again, if we can take the stigma away from it, it is a way to protect our children.
Yeah. And I think when I first saw the commercials about it, it was very direct, the papilloma virus will not get my child. And it was like these parents girded, and they had back off, you're not going to get my child. And it was like, they're going to be attacked if they don't get this vaccination. And I was like, I was horrified. I was like, what kind of marketing was that about?
That's called scare tactic.
The whole country.
Yeah. That's called scare tactic. Yeah.
It was so scary. But that's the thing. Medicine and medical treatment should not be scary. It should be. Go ahead.
Yes. And that is exactly, again, why we just, I would love for every person to have a quality PCP or pediatric doctor, because that is where that information should be coming from. And when when we have communities that don't trust our health systems, then where are they getting that information? And that is just a huge obstacle, even in things like HPV vaccine, right? That is where both parents and children should be learning about that. And if they're not going to the doctor, and if they don't trust their doctor, then where are they going to get that information?
Exactly. Did anyone else have a comment, question?
Hello.
Hi.
Hi, Margaret.
Question. Hi, Viv. Hi, Sarah. My question has to do with the recommended time now between Pap smears, the Pap test, because based on my age, when I was going through that, we actually had them done annually. And I just wondered, what is the research behind that they now have extended that time from 3 to 5 years between your Pap tests?
Yeah, so that's where I talked a little bit how, even when I first started getting Pap tests, that's a more I would say, recent update, because I also got them yearly. And there is this, I don't know what I want to call it, but kind of like theory in medicine, right? Where we don't want to over screen and over not diagnose, but like we don't want to over treat and over test. And so trying to find that balance between where are we catching the most cancers at the earliest right stage without over testing, over treating America for, like the population basically. And so they took data from several years. A lot of data. And that was kind of the sweet spot that they came up with, was the every 3 years. However, our cancer docs, they see cervical cancer, right? And so they're going to recommend, kind of as a LCI doctor recommendation, to still get it every year, because you can develop cervical cancer within that year timeline, but you are not likely to. So it kind of goes back to statistics and research and trying to find that balance between doing more harm than good and more good than harm is where people are floating. And quite honestly, it's probably going to float back and forth, just like mammogram recommendations have floated back and forth, just as they continue to research and gather data. But that's kind of where that comes from. But right now, insurance is still covering it. I don't see it not covering it. And so that's a conversation between you and your doctor of what do you feel comfortable with, again, your family history. And, I was very upfront with my doctor of like, okay, I work for a cancer center. I educate about how important it is. And so I feel very strongly about getting this done once a year. And it's never been a problem.
Yeah, I remember. Yeah, my doctors would always tell me yearly, annual mammograms, annual pap smears. And just recently, my doctor was like, well, if you don't feel any changes, what's the point in doing one? Like if you feel comfortable, and because I always get them every year, both the mammogram and the pap. But now when I go for my healthy checkups, if there wasn't anything prior, like a year ago, my doctor never recommended me to get another pap smear this year. Yeah. So.
And that's exactly the conversation I had with my doctor. She's like, everything looked good last year. You've had normals for the last so many years. Like, I'm good with waiting until next year if you are. And I was like, actually, I'd rather go ahead and get it done, And so again, if you have insurance, that thankfully that is a choice you can make. I think it gets hard when we are dealing with underserved populations. And so how to find them access to that screening if they still choose to have it. And then we still wholeheartedly recommend mammograms every year. And then part of it, Margaret, too, is like how fast the cancer grows. So different cancers grow at different speeds. And so typically, like that was part of what they did in that research and kind of looking at those graphs of, what does it look like if we screen every 1 year, every 2 years, every 3 years for the overall growth of cancer. It's a lot of theoreticals in our body. Does that answer your question?
My question is answered. Thank you.
Okay.
And then I was wondering about the self-checks.
Okay.
As far as your breasts, what are we checking for? Are we checking for a lump as far as a hard lump, or is it going to be fatty tissue? Like what? Because some women, they're not checking their breasts and not actually understanding where to check. Yes. Is it the entire breast area? Is it, because I know, when they do your mammogram, they lift and they are moving all the parts around and they're getting kind of like under your armpit even. So when we do self-checks at home, what should we be looking for? What are the target areas?
So I am pulling this back up. All right, can y'all see that?
Yes.
Okay, so for our breast self-exam, we've got a little diagram here. Okay, so we're talking about, we talked about the breast screening, right? So what Viv is talking about here kind of is that bottom pillar. So your monthly breast self-exam or self-awareness. And, well, I'm going backwards. Oh, what happened? Here we go. Okay, so you're going to begin by looking at your breast in the mirror. So you're looking to make sure they're their usual size, shape, and color, that they are evenly shaped without visible distortion or swelling. So it is normal that your breasts are different sizes from each other, but that your right breast remains the same size throughout your life is what you're looking at. And if you're looking to see changes for such as dimpling, puckering, bulging of the skin, making sure your nipple looks normal to you so that it hasn't changed or inverted, turned inward, and then making sure there's no redness, soreness, rash, or swelling. So that's kind of the first step, is just your general overall, what do you see and observe about your breast. And so you're going to raise your arms and look for the same. So that changes a little bit kind of the shape and picture that you have of your breast, and making sure there's no fluid coming out of your nipples. And then you're going to kind of monitor up to your collarbone, really to your rib cage, right? And then you're going to go chest plate to underarm, because that is where our breast tissue is. And then what I always say is, if you're not sure if it's a part of your breast or your underarm, but you find a lump, like you've still found a lump that needs to be looked at, right? So like, don't feel like you need to go all the way through your stomach, but like you are gonna check again, breastplate to, I mean, your breast goes onto your side a little bit, right? So under your arm, and then again, top of your rib cage to the bottom of your collarbone. And you're going to, ideally for a thorough exam, you're going to do it in 3 different ways. And so that's going to be vertical, up and down. By 3 different ways, meaning 3 different pressure points. And then you can choose whether you want to cover the whole part. You can do vertical, which is up and down, circular, so kind of working from your outermost corners into the center, or almost looking at it like a piece of a pie, just to make sure you're getting a comprehensive screening of your breast. You can do it sitting or standing. And then we have these models, which is super helpful when we're in person, where there is a model where you can feel a lump that is more on the surface and requires a softer touch, which is kind of what I was referring to. And then there's a model where it requires a deeper touch or a deeper pressure. And so we really encourage patients to do both. So you're doing, you're going to use one of these choices of patterns and do a lighter pressure. And then you're also going to do one of those choices of patterns and do a deeper pressure, because again, it's hard to describe over the internet, but like it just showing you the difference of what a lump could feel like. And that could be something hard. It could be something fluid. It could be something movable. I think the biggest thing to just notice is that like something is there that wasn't there before, and then leave it to your doctor and your medical team to look into what that is and what the next steps would be.
Yeah. And I think any type of change in breast size, it can be due to, if you're still menstruating, also, the type of workout you're doing.
Yeah.
A lot of time you can get developing enlarged breasts based on the back of muscles underneath, so there's a lot of changes that can happen over time, especially when you're older. They can also sag, and new things can develop by I know if you lose a lot of weight, things can appear that you didn't know was under there because you had fatty tissue covering it. So, and not every lump is going to be cancerous, which is the bright side. It could just be fatty polyps, fatty stuff.
I think it's 8 out of 10. So 4 out of 5 are usually non-cancerous. But still, we just want to make sure. And again, you're going to be your biggest advocate in being aware of your body and changes that are happening.
And then I also had a question about the cervical side.
Okay.
As far as the bloating, I know you're talking about the menstrual bloating, and maybe if you eat too much pizza, you'll get a big old fat stomach, or if you're if you indulge in drinking or anything, you will bloat. So what type of bloating is the sign that might be a issue for your doctor to know about?
Yeah, so what we kind of say is anything that's persistent. Okay, so if you normally bloat the week before your period, and it's like before your period and you have a bloaty day, then like that's not going to be a reason to call your doctor. Or if you bloat after you have a heavy carb day and then it returns to normal in a day or two, that's not really a reason to call your doctor. But if you've realized, and again, are aware that like, oh, like I've been bloated for a couple of weeks now, and like food isn't changing it, exercise isn't changing it, that is one of those things to be like, okay, what's going on here? Because it could be GI related. It could be, there's several things it could be, but noticing that like this doesn't fit the pattern that I'm used to, or doesn't have a explanation that is normal to my body and my activity.
Now,
that's more of what you're looking for.
Is bloating in the lower part of the stomach, or can it be the whole stomach?
I think either one. So again, it could be GI related if it's your upper stomach, or it could be, we also have lower intestines too. And so you're not going to know the answer to that. And so the best thing is, if there is any type of continued or unexplained bloating, to go talk to your doctor about it.
And what about discharges? Are discharges signs of some sort of cervical cancer, or is it just, maybe you need to, clean up a little more?
Yeah. No, again, I think I think the biggest differentiation is like if it is continued, right? Like they are going to, like our body does miraculous things. And so there are going to be times when our body's taking care of something we don't even know it's going in our body. And so we may have discharge, right? But that is the exception and not the rule, is kind of what is how we're going to go about it.
And it's probably case to case, person to person.
Yes.
Because it also can be affected by your diet. If you have a certain allergic reaction to something, or if you have, let's say, a minor yeast infection, or, it could be menopause.
Right.
So there are different parts of, especially the woman's cycles, and I'm not just talking about a period cycle, but you have a menstrual cycle,
life cycles,
and life cycles.
Yes.
So,
and so it's more when like it is persistent. So again, something that's like, okay, I've been, having discharge that smells really bad for like 2 weeks now. Like, what is going on, right? Like, so again, having that conversation with your doctor. Or I've been spotting for over a week and I just had my period 2 weeks ago. Like, what is going on? Like, any of those times are reasons to, if you have the online access, to just send a message and be like, hey, is this normal? Right? Like being aware that like what is going on, and when do we need to look at this further? And your doctor is going to be the best person to be like, yeah, like come in, let me do an exam, or that's fairly normal, let me know if it doesn't change in a week. Like they are going to be your best resource. And so it's, again, making sure like if it is persistent or out of your norm, that is when you would reach out to someone.
And I know when you have like several children, I saw in the statistical information you were giving, when you have multiple children or you become a certain age, your uterus can drop, and it will change shape and chemistry, if that's the proper way to say it. And I know that some of us wear pads, even if it's not for people think menstrual cycle, but it's also for urination. So can a cancer be a part of that, as like having the sign of constant urination, or a combination of the discharge. Is that something that can?
I mean, it can be. One, I would highly recommend if you have access or talking to someone to see a pelvic floor PT. That is like a huge women's access issue, right? Like I feel like anyone who has been pregnant or has had a baby or birthed a baby in any way should see a pelvic floor PT. Just to deal and strengthen their pelvic floor and bladder issues, right? So can it be a sign and symptom? Yes. Does it mean it's a sign or symptom? No. But again, going back to having that conversation with your doctor, like, hey, I've noticed this, or hey, I'm leaking real regularly, or I have to pee, every 30 minutes, it feels like. And so, that will then, at least in my case, encourage them to do like some bladder test and some vaginal ultrasounds to just make sure that it wasn't related to cancer or growth or a tumor. And then kind of realizing like, oh, like this is how, my body has a small bladder and makes a lot of urine. So I'm going to have to pee a lot, but making sure that that's normal for me and not the cause of something bigger.
Yeah. Some women have fibroid tumors, and that will cause an extra, it looks like a discharge, but it could just be that every month, a certain time a month, as if it's an actual period. So it's interesting how our bodies work and, like you say, heal, because some of these things that are coming out need to be out. If we keep them in, that's where those viruses and cancers can gestate, if you would say, and keep us not healthy. But I tell you, the best thing out of this today is the conversation. We have to have these conversations, especially with our doctors and our healthcare providers. And I'm so glad that you were able to share this information with us. Before we go today, is there anything else is there a question or comment or anything that any of our guests would like to ask? Okay, well, we're looking pretty. I am so grateful for you today, Sarah, and Atrium Health, and I hope that our next segment will bring as much fulfillment and education for us. And we at the library here at Charlotte Mecklenburg Library System are going to provide these accessible videos and teachings because it's just a conversation we have to continue to have. So
it is.
I'm looking forward to next month and conversations about what our Levine Cancer Institute partnership has for us and our surrounding areas. I'm glad to reach out and teach out. That's how I look at this. It's a reach out and a teach out moment.
Yes.
Yeah.
And please, anyone who listens to this at any point, if you have questions, there again is my cell phone number and my direct email. So please don't hesitate to reach out, just like Viv said.